This episode of Talk of Hope has been sponsored by J&J Innovative Medicines. J&J Innovative Medicines has had no editorial input into or control over the content of this podcast.
Hello and welcome to Talk of Hope, a podcast for people affected by lung cancer. I'm Rachel Avery. Each episode we'll hear from people with different experiences of lung cancer, as well as healthcare professionals who will share what's going on to improve the diagnosis and treatment of this disease. Because amongst all the fear and anxiety that comes with lung cancer, there is also hope, and that's what we're choosing to focus on here. Hearing the words, "you have lung cancer," is utterly terrifying, and even more so when you're told it's incurable. But what's important to know is that the way we treat lung cancer has changed a lot in recent years. Even when someone's cancer can't be cured, it can still often be treated really effectively. Thanks to advances in precision medicine, more people with stage 4 lung cancer are living longer, fuller lives than ever before. In this episode, we're exploring what precision medicine means, how it's changing treatment, and what it's like to experience it firsthand. And to help us do that, I'm pleased to welcome patient advocate Duncan Edmonstone and consultant clinical oncologist Dr David Gilligan. Hello to you both.
Hello.
Good evening.
Just want to mention my co-host Mandy. I'm flying solo today. Mandy's not feeling too well, so chaps, you've just got me today, I'm afraid. And I will do my best to get loads out of this podcast because it's a really, really important topic, and I think it's something that really demonstrates how much progress we're making in treating this disease. So, David, I'd like to come to you first if I can. Can you kind of talk us through in simple terms what precision medicine is and how it differs from kind of the traditional treatments like chemotherapy, radiotherapy that we use to treat lung cancer?
Yes, Rachel. So precision medicine covers a number of different areas, and really there's been a massive expansion in precision medicine for lung cancer. It's one of the leaders in the field of all cancers. You're absolutely right that chemotherapy and radiotherapy have been used to treat lung cancer for many, many years with varying degrees of effectiveness. And sometimes precision medicine is used together with radiotherapy or chemotherapy. So we mustn't forget that they are complementary to these new treatments. I'd say that to try and keep it as simple as possible, probably precision medicine falls into 3 different categories, I would say. First of all, we have what I would call targeted therapies. So there are a number of molecular abnormalities within tumors, specific lung cancers, and they're becoming more and more developed, and more advances are revealing specific molecular abnormalities. And drugs have been developed to target those molecular abnormalities. So any particular drug will only be effective against a particular molecular abnormality. But in that situation, it usually provides a very effective treatment, and normally with much less in the way of side effects that are associated with chemotherapy or radiotherapy. So the second category is immunotherapy, where certain tumors we know respond to immunotherapy. And immunotherapy, if you like, allows one's own body's immune system to see the tumor as being abnormal and shouldn't be there. Normally, tumors have built-in mechanisms to hide themselves from the body's immune system. And what these immunotherapy drugs do is, in various ways, unmask the tumor so that the body's immune system, your own body's immune system, can see the tumor and attack the tumor. And then I suppose a third category, which has become up and coming in lung cancer, is something called antibody drug conjugates. And what these are antibodies which are targeted against particular molecular abnormalities, but tagged onto them, a bit like a magic bullet, is a chemotherapy drug. And then that chemotherapy drug is targeted much more precisely to the cell and releases its payload, if you like, in the cancer cell, and is much more targeted in the way that it works. So I suppose those are, from my point of view, those are the three main areas of precision medicine. But of course, there's actually masses more happening, and it's really quite difficult to keep up with all the developments. But those, I would say, for the purposes of now, are the ones that we need to focus on.
Yes, let's keep it as simple as possible. Although it is exciting to know that so much more is happening. And I suppose, you know, I mean, I won't say how long you've been an oncologist for, David, but, you know, it's a few years. And I imagine, not being rude, you know, in that time, you must have seen so much change. You know, the conversations you used to have with a stage 4 patient when you're telling them it's incurable and not really that treatable, compared to now, where we are seeing people live really full, long lives, even with incurable disease.
Yeah, absolutely. Yeah, I mean, I'll be honest. I've been a consultant coming up for 30 years in the summer.
Don't believe it. Don't believe it. No, definitely not.
And when I first started, I had maybe 1 or 2 different chemotherapy regimes that I could use, and they were pretty toxic. They were pretty horrible. They made people feel very unwell. And the best that one could hope for was that they kick things into touch in terms of the disease for, you know, a few months, maybe at best for a few people, some years. But now that has changed for many, many people, and people are living with lung cancer. So it's become if you like, living with a chronic disease, what like one might live with arthritis or diabetes or another disease which is, you know, well known but doesn't have the same stigma as cancer. It brings its own challenges because living with it alongside it is very different, and we have people who I'm sure Duncan will probably enlarge on this, but you know, you have a scan every so often and you're waiting for the results of the scan. Is it still working? Is it not working? But we are hopefully addressing those challenges and helping people who are living with their lung cancer, alongside their lung cancer that's being kept at bay and living full, active lives without too many side effects.
It's a nice problem to have. You know, 10, 20 years ago, we would have killed for that problem to have to, you know, help people live even longer. Duncan, bring you in then at that point, because, you know, this is your situation. You are living with stage 4. It's ALK positive, so that one of the mutations that David was talking about, your specific mutation is ALK positive. And you did hear those words, you have lung cancer and it is incurable. I mean, can you talk us through that kind of moment of diagnosis and ultimately the heartbreak that you must have gone through?
Yeah, well, it's I was slightly unusual in that, well, not that unusual, to be honest. I was an emergency presentation. My diagnosis happened.
Fortunately, not unusual.
No, emergency presentation, but unusual in that I had no symptoms before suffering a seizure out of the blue. I'd known none of what you call the typical symptoms of lung cancer, you know, cough, chest pain, weight loss, any of those sort of things. Didn't have any of them. Just had a seizure out of the blue. My wife thought I was having a stroke, and I was taken by ambulance to my local A&E department. And about 5 or 6 hours after being there, I'd had chest X-ray and an MR scan, which is not unusual for someone who suspected stroke patient. And the emergency medical consultant said to me, the reason you had a seizure is you've got a large lesion in your brain. You've got 2 more lesions in one of your lungs. We can't say until we do a bunch more tests, but we could be, sort of 90% sure right now that this is lung cancer, and it's stage 4 lung cancer. And I know that I have a few relatives in the family who've had cancer, so I knew what stage 4 meant in terms of what I should expect from that straight away. So there was no sort of preparation. There was no getting ready for bad news, because it was out of the blue. I'd literally done a day's work, and 4 or 5 hours later, I'm getting told you're probably going to die. And so I was in shock. I don't think it was a case of how do you cope with the words incurable. I just went into shock. And I'm not sure I really came out of that until after about 6 weeks later, when I was told that they identified the ALK fusion, and the sort of treatment regime obviously then changed at that point. That was really the point that came out of it. So, yeah, I as a non-smoker as well, you kind of stage 4 lung cancer. It just didn't compute at all in my head, and it wasn't it really wasn't a question of thinking how do I of trying to cope with it, because it was just shock. And I think add on to that the fact that because you had a seizure, they put you on some fairly strong steroids, and you end up with a sort of in a permanent state of having a fuzzy head. You don't really know what's going on either. So I kind of learned about a lot more about what it meant after the fact than at the time for me. But it was still, like I say, a huge shock out of the blue.
Yeah, I mean, like you say, I mean, it's not uncommon to kind of have that symptom come out of the blue, and I think it's around 30% of people, David, is it, that's diagnosed through A&E emergency presentation. Yes. It's it is very high with lung cancer, but to have no other warning signs, like you mentioned, the persistent cough, or even just feeling tired or unwell, or anything that kind of hinted that maybe something is not quite right, but all of a sudden to try and get your head around that, and like you said, the added element of it being lung cancer as someone who hasn't smoked is still something that people are grappling with, and something that we as a charity are very much trying to highlight, that you do not have to smoke to get lung cancer. Understandably, it took a fair few weeks for you to get your head around it and start to process the situation you were in. You mentioned that you were then told about the ALK fusion diagnosis. Yes. So how did that then change your kind of treatment journey, and how was your treatment then explained to you, and what was involved?
Well, I mean, in terms of the treatment, it obviously came as a huge relief, because previously I'd actually, by the time I was told that I had the ALK fusion, I'd already had a craniotomy and brain surgery to remove the tumour. It was luckily in a really operable position. It was just considered that it was something that I could get on and do. And then interestingly, of course, once the ALK fusion was detected, it's an interesting conversation I've had with my own oncologist many times, of if that had come through before the surgery, would we have even gone ahead with the surgery? Possibly not, because it may not have been necessary, because the treatments, the targeted therapies are so effective that they could possibly have dealt with the brain tumour without the risk and the worry of going through surgery. But we'll never know on that front, because it happened. But yeah, I was sort of preparing myself for radiotherapy, for chemotherapy. And I was preparing myself to get my house in order because I was going to be dead in a year, because I looked at the median survival rates for a stage 4 lung cancer patient, and it's brutal. So, I sort of saw no reason to, at that point, to see why I would be an exception to the rule. So, yeah. So when my oncologist said to me, "You've got this particular type of lung cancer, ALK positive, and you're not going to have any radiotherapy. You're not going to have any chemotherapy. There's going to be no more surgery. You're just going to take these tablets every day." I mean, at first you think, what? Really? That's totally flipping things on its head. But I was lucky enough, sort of at the same time as I got the diagnosis, the lung cancer CNS, clinical nurse specialist, pointed me at a support group, which I joined, and I instantly started talking with people who were taking the same treatment as me and had been taking it for years. And that's for all that your clinician can say to you, the outcomes with this medication are much better than what you might have been expecting. Actually hearing from other people saying it was what really drove home the message. Hang on a minute, I'm not for it yet. I've got some life left to live, and that was a thrilling moment when I realised that. Let's say it was a few weeks after getting the ALK positive diagnosis.
It is, and it's so important, and that's why we're so grateful to people like yourself that will come on and share your experience, because no doubt there'll be someone listening who was in your position. Is it 6 years ago you said you were diagnosed?
It's over 6.5.
Over 6.5. So there'll be someone who, 6.5 years ago, back where you were, thinking the same awful thoughts, preparing to not be here in a year's time, and then hearing that 6.5 years down the line, here you are, and life is good.
Got questions about precision medicine, or unsure whether it's an option for you or your loved one? Give our nurses a call and find out more about these treatments and whether you can benefit. Call 0800 358 7200.
David, so Duncan has a particular type of lung cancer called ALK fusion, ALK positive. Can you just talk us through some of the other types of mutation and how other kind of treatments match with those? So obviously we talked about the genetic mutations having the targeted therapies, who might have an immunotherapy and that sort of thing.
So the targeted therapy, the sort of therapy or the sort of treatment that Duncan is taking, they tend to be tablet based, but not exclusively. Some of them are antibodies, which have to be given either by a drip or by an injection under the skin. But there is an increasing number of therapies available to target, as I said earlier, specific mutations. Probably the most well-known, as well as ALK fusions or translocations, is something called EGFR positive lung cancer, which is epidermal growth factor receptor. And that has a number of things in common with ALK positive, and it tends to be more common in people who have never smoked. Why that is, why people who've never smoked get lung cancer of this type, is we're still really trying to find out and work out. There are some studies going on that will maybe give us some of the answers in the next few years. But there are also some other targeted therapies which may not be associated with never smoker lung cancer. There's one, KRAS is a particularly common mutation that we see. Maybe up to 25% of lung cancers will have a KRAS mutation. Some of them will have a very common mutation called a G12C mutation, without getting too technical, but that can be targeted. And that's something which is more common in people who have smoked. So it's not, these targeted therapies are not exclusive to people who have never smoked. And there are probably now about 7 or 8 targeted therapies, or therapies which molecular abnormalities in lung cancer, which can be targeted through drugs. And as I say, more and more drugs. There is a what we call a pipeline, if you like. It's a sort of we know that drugs are being tested, and many of them are showing huge amounts of promise. So there are other molecular abnormalities that might not be targetable today in March 2026, but maybe in March 2027 or March 2028, there will be more targeted therapies. So both new molecular targets will be found in what's called druggable, treatable with drugs, or, and it's particularly the case with ALK positive, that if your one particular drug stops working, there may be another drug which will come along and take over from where the last one left off, because it's a bit like antibiotics. Sometimes tumors become resistant. They show resistance to the therapy they're on, and you may need to go on to a different therapy. With immunotherapy, that's slightly different, and the abnormality is not molecular, but we know that we can do tests on biopsies to tell us who might be more likely to respond to immunotherapy. And that means that we can tailor treatment more specifically. So some people might respond just to having immunotherapy on its own, but other people, you might have to add in immunotherapy and chemotherapy for a bit and then carry on with the immunotherapy.
How's immunotherapy given?
Well, traditionally it's been given as a drip in the arm, but like conventional chemotherapy, every 3, 4, or 6 weeks. But there's research going on to see whether or not we can give it less frequently, maybe every 12 weeks or 18 weeks. And also, a number of immunotherapy drugs are now being developed where rather than you give them intravenously, they can be given with what's called a subcutaneous injection. So that's an injection under the skin. You don't have to find a vein, and they can be given in much shorter periods of time without having to find veins to inject the drug into, which is not quite as good as taking a tablet perhaps, but maybe not quite as traumatic and quite as lengthy as having an infusion of a drug.
It's fascinating that even kind of within that, there's still constant improvements, isn't there? So immunotherapy, new treatment in itself, but now we're finding ways to give it better, or finesse it and streamline the process. It's just, I can't get over how much is happening. It's
and what's also happening is that combining other biological drugs with immunotherapy. So we have things that traditionally immunotherapy has been aimed at one particular abnormality or unmasking the immune system. But now you've got drugs which are really, really clever, and they can do more than one thing. They can target different parts of the immune system, or they can attack the immune system and the ability of stop the ability for tumors to produce new blood vessels. And there are lots and lots of clinical trials underway looking at sort of the next generation of immunotherapy type drugs, which are really amazingly clever. And so I'm sure that over the next decade, I might not see them after being a consultant for 30 years, but my successors will be using these drugs with increasing rates of success.
Who's living with this disease, it must fill you with so much hope.
It does. So one of the things that reassures me in my own, and what we touched on earlier, this thing of living scan to scan, and everything associated with that, and you kind of end up living in this liminal space where you struggle to plan too far out because you find it difficult to plan things past the next scan, but you should, because the chances are you've got a life to live. You need to get on and live a life. So that's quite difficult. But one of the things that gives me hope constantly is that I know that I'm very lucky that I'm still on my first line treatment. It's still working 6.5 years after I started taking it, which is quite incredible. But I also know that if it were to fail, and if the cancer were to find a way to become resistant to it, mutate around it, whatever, there's a second line drug available that I could move to that would have a reasonable chance of being effective as well. And I also know there's another drug currently in trial beyond that's looking really promising. So you kind of look at this and think, okay, so I'm living this life of scan every so many months, and I'm living this life on the edge of this terminal diagnosis all the time. But also, there's so much hope. There's so much possibility that there's going to be that we're ultimately going to get to a position where it ceases to become a terminal disease. I don't think for all lung cancer, but certainly for some types of lung cancer, it ceases to become a terminal disease and it becomes a chronic but manageable disease. I think whether I'll be in the first cohort of people that get there, I don't know, but there are people who are being diagnosed now that I think will.
That's what an incredible statement to be able to make, because certainly that wasn't the case when I joined the charity, and when David.
I don't think it was even the case when I was diagnosed six years ago. I think when I think about my own support group, that we had a few members that were at sort of 4 or 5 years post diagnosis. We've now got members that are over 10, and so it's and once you get to that point, you're thinking, well, ultimately, is it going to be the lung cancer that's going to get them in their end, or is it going to be some other cause anyway?
I mean, let's keep it light, Duncan. Come on, talking about kind of day-to-day life. Then we've touched on kind of scans and living in that kind of interim period. Like, how has the treatment impacted on your day-to-day life, or has it? How is the quality of life on this type of treatment?
I mean, generally, it's really good. These are what the medical term is cytotoxic drugs. So they're powerful drugs. They're designed to kill certain cells in the body, the cancerous cells. But the upshot of that is there are some side effects. There are some things that need to be managed, but they're mostly tolerable, and I live a pretty normal life. I'm not restricted in what I can do in any way. In fact, I was back working full time within 3 months of my diagnosis, and carried on working for over 4 years, and then had an opportunity to take early retirement, which I grabbed with both hands. But across those 4 years of working, I can only point to the typical big side effect you get with a lot of these treatments is fatigue. And that's kind of, if you list one thing that's on nearly all of them, it would be fatigue. And across those 4 years of work, I can only think of 2 or 3 days where I had to call my manager and say, "I'm sorry, I can't do it today." But apart from that, I just got back to working as usual. So that was, I know I'm one of the lucky ones. There are other people that have more complex reactions to these medications. They can have kind of liver and kidney issues aren't unusual either. But it is possible to live a normal life while being on these treatments. And I'm living proof of that.
And I think it's important to highlight that everyone will respond differently to the treatments, and they will have different side effects. And that's what your lung cancer nurse and your medical team is there to help support you with as well, isn't it? It's, so if you are experiencing any kind of side effects, it is important to, don't be stoic, don't just try and get through them. Tell your team, because there are then other treatments that can then help counteract those side effects. And I think that's a really important thing to highlight, because, like you say, some people might not really experience many side effects and other people will. And don't be worried if you're experiencing those side effects and other people aren't.
Yeah, and the thing I'd add to that is that you do get some people that don't want to report side effects because they're worried about being taken off the treatment. And I hear this in my support group all the time, and I always say to them, the last thing your medical team want to do is take you off your treatment. That is the absolute, that's the last recourse. They don't want to do that. Report whatever the problems are, and they'll probably find a way around it, because there's, for most of the side effects, there's a way around. There's something that can be done.
David, you're nodding there. Just bring you in just to say that from a medical point of view, Duncan is correct.
Absolutely, and I think that raises what Duncan said raises a number of very pertinent points. So you mentioned your nurse specialists, and they are almost always fantastic at being a point of contact where you can speak to them. They know about the medications that people are on. They've got a lot of experiencing in advising people how to cope with the side effects in terms of other medications, or having a short treatment break, or having a reduction in dose, and those things, particularly having a short period of time to recover from the side effects, or having a reduction in dose, do actually scare quite a few people, because you think, well, it's not going to be as effective. But the evidence that we've got for most of these drugs is that if you do reduce the dose, you don't actually lose any of the effectiveness of the drug. So it's important to understand that. And the other thing that comes across, and I think we as specialists really need to take on board and rethink, is the whole area of what other people call survivorship. So about living alongside the cancer, living with it as a more chronic condition. And because we, as historically we've treated people in very different ways, and we need to do a lot more work in looking at how we can support people in that space. Do we need to scan people as often as we do? Is that a good thing? Is that a bad thing? There needs to be research on that, I think.
I think that's a very personal choice, isn't it? I mean,
Duncan,
how would you feel? Like,
there's a dilemma. I mean, you can ask Duncan. I mean, there's a dilemma of whether, how long do you leave it between scans? Because is it the coming up to the scan that causes the problem, or is it the wait between? What is it that is causing the anxiety? And I think there needs to be a lot of research on how we can support people in that space, and how best to alleviate some of the anxieties that people will inevitably feel.
Do you have any thoughts on that, Duncan, from your point of view?
So I've not, as of yet, altered my scanning regime. I'm still on the default of every 3 months. But I've discussed it. I've discussed it with my oncologist, and we've for the time being decided to stay where we are. But I think it is a very personal choice, and I think it comes down to the degree to which you worry get that whole thing which people call scan anxiety, which is the worry leading up to the scan and immediately after the scan before the results come in. And I think one of the things that causes that in some areas is that unfortunately in some treatment centres, the time between the scan and the results can be longer than it really should be. The good centres get that right and make sure that's a short period of time. And then I think the other thing that some people worry about is that every single time they go for a scan, particularly the CTs, they're exposing themselves to X-ray radiation again, which they're getting. I can't remember what it is. Several years of background radiation in one go, compared to what a normal person would receive. Now, is that good or is it not? We don't really. They say, as David says, there's probably not enough research done into that, but people get concerned about it nevertheless. I've not seen reason to change at the moment, and maybe I will in the future, but I've stayed where I am for the time being.
I suppose it could be that peace of mind, once you've had the scan, you've got those results, that kind of, it's almost that little bit of peace of mind for that next period of time, isn't it? And if you elongate that, do those doubts and fears start to creep into your head of what if it is?
Well, there's always this thought that the earlier you catch progression, the more options are available to deal with it. Is what a lot of patients are kind of aware of. Although how much difference a month makes, if you went from 3 months to 4 months, I don't really know. It's something I think that's in the back of people's mind, is like, look, we need to be able to catch these things as early, because then there are more options on the table in terms of what we can do to treat them.
I think it's a whole different podcast, this topic, isn't it?
Gone off on tangents, sorry.
They're the best kind.
Follow in Duncan's footsteps and join our patient advocacy network. Our advocacy programme aims to build a strong, active and diverse community of patients and supporters who represent the charity and champion lung cancer awareness, early detection and improved outcomes. For more information, visit roycastle.org/advocacy.
David, I would like to bring you back in to talk a little bit about genomic testing, please, because obviously this plays a really big part now in the diagnostic process and identifying people that are going to benefit most from these precision medicines. Can you kind of talk us through genomic testing and also the importance of kind of potentially retesting, rebiopsying, and also now the role of liquid biopsying?
Yeah, well, that's another great advance that we have. So in order to prescribe these targeted therapies, we need to know what the molecular abnormality is. And historically, you need a biopsy, you need a piece of tissue, either obtained through a bronchoscope down into the tubes, or a biopsy on a CT scan, and there is emerging technology in improving all of those things as well. That's probably for another podcast. And what traditionally happened was that you had a biopsy, it went off to the pathology lab, and the pathologist looked at slides underneath the microscope and said, yes, this is lung cancer, or this is a particular type of lung cancer. And that was really it. Now we can do very clever molecular tests on the DNA and the RNA and the tumor. The problem is that these tests take time to come back. There's quite a lot of debate about what should be the best practice and time and the turnaround between having a biopsy and getting these molecular results. Best practice is probably saying that it should be within 14 days or 2 weeks of having the biopsy. In practice, we're finding that's not the case. It can be up to a month to get the full molecular profile of a tumor. And that means that there's wait and wait and wait until you know whether there is a molecular abnormality and what treatment that you might have, whether it will be a targeted treatment, whether it will be immunotherapy, whether it will be chemotherapy or some sort of combination. So we need to look at how we can streamline the whole process from getting the biopsy to getting the molecular result. Alongside that, running in parallel, is something now that we can do called a liquid biopsy, or ctDNA, which stands for circulating tumor DNA. And what that is a blood test which can measure tiny amounts of tumor DNA in the bloodstream. And the molecular abnormalities can be amplified by very clever molecular technology to tell which molecular abnormality is in the bloodstream. Now, that is, first of all, much easier than having a biopsy. Having a blood test is so much easier than having sort of tubes down your throat or needles stuck into your chest. And you can get a result, again, more quickly. It has its limitations in that if you don't have a molecular abnormality, you still need to know more information about the tumor as to whether immunotherapy might help or other therapies might help. And not every test, not every liquid biopsy test will, even if there is a tumor there with a molecular, it might not show that molecular abnormality because it's based on, I suppose, how much tumor is actually there in the body. But that has changed things, and some people will get the result back much more quickly. And if they've got a molecular abnormality, it means they can get onto the targeted treatment more quickly. And in some cases, a few cases, it might mean they might not even need to have a biopsy. And so this technology, in most parts of the UK, particularly NHS England, have funded this to be done so that people can have hopefully much more quick access to these targeted therapies.
And I'm guessing, given you were diagnosed 6.5 years ago, you wouldn't have had a liquid biopsy.
No,
It would have been a traditional biopsy.
I had a traditional biopsy. So what's interesting here is this speaks exactly to the point that David was making about how long things take. Is, you know, I had to wait 2 weeks from my presentation to going for my biopsy, and then it was another 2 weeks after the biopsy to get the results of that, and that was a classic tissue biopsy taken by a CT guided needle, and obviously at the time, ctDNA, a liquid biopsy, wasn't standard of care. There were a few trials going on in the NHS at the time, but it certainly wasn't standard of care. So it didn't. I didn't get that. Now, if I had it, as I said earlier, I think there's a very strong chance they would have cancelled my brain surgery, and put me straight onto the targeted therapy. And that would, I mean, there's a good example of why that would obviously be a good thing for me, but also a good thing for the NHS in terms of and I imagine the cost of putting someone through a full craniotomy is fairly expensive. So that would have been a very good thing for the NHS as well. And would have got me to treatment a little bit faster. So yeah, it wasn't there when I was there, but yeah, it's certainly we certainly see it as something that most patients I come across have been through now. I think that the interesting challenge with the genomic side of it now is that although it's kind of, the liquid biopsies have very much become standard of care in NHS England, clinically, I'm not sure they're there operationally in terms of people, process, and technology working as they should. to actually really get the benefit out of it that is possible. That's the bit that a little bit more work has to happen on.
And I'm sure it will. It's it's another step forward, isn't it? And as we said, with the different types of treatment, the immunotherapy now being given in a slightly different way, it is about refining that process each time.
Yeah, absolutely, and Duncan's absolutely right. I think we've got these amazing technologies, and we just need to refine them so that we use them to the best ability, that to streamline what we do, to make sure that we don't repeat things that don't need repeating. And it's working with the technologies, but that's a good thing to have. I mean, it's good that we've got them, and we just need to sort of tweak them and refine them to make sure that things happen as quickly and as efficiently in the right order, so that we use the tools that we've got to the best ability.
You mentioned the robotic assisted bronchoscopy before, David. I have had a play on one of those, and it's so exciting. Honestly,
yeah, well, I said that would make me for another podcast, and I think you're absolutely right. It's going to really change how we get tissue and biopsies. There is a big problem there, that it's very, very expensive, and it's very, very restricted in availability at the moment, but hopefully those things will change.
Definitely. I'm conscious of time. I mean, we could keep chatting on this for a long time, I think, but a couple of last questions. David, come to you first. And so, I mean, we've touched on this a little bit, but looking ahead, where could precision medicine take us in the next decade, in your opinion?
Well, we haven't touched on these drugs being used at an earlier stage, and that's kind of what happens, and that we're finding now and testing people who have surgery for these molecular abnormalities, and giving people who've got molecular abnormalities with surgery these treatments, and that seems to be very effective in reducing the chance of the cancer coming back. So that's another area. We've talked about using different lines of treatment, that when one stops, then the other one might come in and take over. And then the other thing I talked about was certainly in the immunotherapy space, different drugs attacking different parts of the immune system, and that's going to be a really big thing, I think, happening over the next few years. But there's so much happening. There's a whole there's a whole industry. There is many aspects to the pharmaceutical development of these drugs, but I think we're going to use them hopefully more. We're going to use them hopefully with less side effects, and letting people live full and normal lives, as I hope Duncan is doing.
And that brings me on to my last question for you, Duncan. So 6.5 years since you were diagnosed, kind of what have been your highlights? What have been your achievements in those times? What have you got to do that you didn't think you would?
Well, I like I say, getting to return to work was the most in the short term was the most amazing thing, because you'd think you might not want to, but I was really desperate to. When you get that sort of stage 4 diagnosis, and the whirlwind you go through during the early stages of that sort of rapid cancer pathway that you go through, you kind of crave a bit of normal at the end of it, and going back to work was the normal I was craving. So doing that for 4 years was great. I've stopped working now, so I very much enjoy doing a lot of patient advocacy work. I work with my local Cancer Alliance. I work with a cancer charity, and I also do a lot of work with patients that have lost their driving license due to brain mets, because it happened to me. And it's an incredibly complex area that I've learned an awful lot about, and I've helped an awful lot of patients now get their licenses back when they're their diseases in their brain has been found to be stable. So that's I've really enjoyed doing that. I mean, and on a personal perspective, I'm getting the chance to go on some amazing holidays as well. Me and my wife spent a month in New Zealand a couple of years ago. That was incredible, and more things to come. I'm going on a cruise of the Mediterranean this weekend for 2 weeks. So lots more holidays like that to come.
Wonderful to hear. I'm going to get you back on the podcast for the next series, and we're going to do an episode about driving license and brain mets and the DVLA and all of that. Will you come back on for me?
I can talk
Brilliant.
your hind legs of a donkey about the subject.
That's great. That's what we like to hear. It is so important. It's that sense of normality, I think, for to have that taken away from you, that independence. I've spoken to a lot of people about it, that was a really hard one for them to take. So I think, yes, let's absolutely do a podcast on that. Gentlemen, it's been an absolute pleasure to spend the evening with you both. Thank you so much. It's been very, very insightful, very, very exciting times, and very, very hopeful. And I hope people that are listening can take that away from from the medical side of it, David, and kind of what is happening now and what's imminently happening in the future, and then Duncan, your lived experience to show that there is life after a diagnosis, even at stage 4. So thank you very much for joining me, and I will see you both soon.
Thank you, Rachel.
Thank you very much, Rachel, and really nice to meet up with you, Duncan.
Thank you.
Talk of Hope is a fortnightly podcast from Roy Castle Lung Cancer Foundation, with new episodes released every other Tuesday. Like and subscribe to make sure you never miss an episode.